You mentioned one inhibitor as a targeted therapy, but there's a couple of others. Would you briefly tell us about those?
So over the years, recently, we have identified certain specific targets in AML, which are resulting in the addition of medications on these standard backbones. So the target for venetoclax is something called BCL2, and actually venetoclax probably makes all chemotherapy better. It's kind of a controversial statement, but I'm going to stand by it that in AML, it has been shown that the addition of venetoclax to lots of different backbones makes them work better. There are other things to hit, though. For example, there are patients with AML who have something called a FLT3 mutation. This mutation also has specific inhibitors that are FDA-approved drugs that target specifically the FLT3 mutation. And if you have one of those, your doctor may add on a FLT3 inhibitor to either a lower intensity or an intensive backbone. Similarly, there are agents called IDH inhibitors. There are IDH1 and IDH2 inhibitors. If I start getting into isocitrate dehydrogenase pathways on this webinar, I think everybody will click off because it certainly bored all of the medical students in med school, and it's pretty tough to understand. But the bottom line is it's very cool stuff, because that boring pathway in medical school that nobody really thought about too much is actually part of very, very central cellular functions that are a vulnerability now that have been identified in leukemic cells, that if you hit them with these specific inhibitors, patients do better. Now, a couple of things for patients. It doesn't mean that it's better to have a FLT3 or an IDH mutation because the targeted therapies are available. So a lot of patients are disappointed when they don't have mutations. I don't want you to think in that way. It's not that it's better, it's different. It identifies a different biology. If you have certain mutations, there are certain medications that may help you more. And that's why I think the patients are learning quickly too to ask the doc. They may not remember the letters of the alphabet soup, but do I have something about my AML that can get one of these targeted therapies added on? I think is a good question to think about. That do I have something about my disease that has a specific drug that we've already learned makes outcomes better?
And there's a new emerging therapy as well. Is it menin or menin inhibitor?
So the menin inhibitors, I think that in understanding different targets and different pathways, it leads me to kind of just a general statement that AML clinical research, if you can get yourself potentially onto a clinical trial at an academic center, that is something to consider right out of the gate, because there is a lot going on in this field right now. And what we are hoping, and the reason that I'm talking to you about venetoclax and FLT3 inhibitors and IDH inhibitors, is because of all of the patients who jumped onto those clinical trials and proved that those drugs are better. And some of them are my patients. I was fortunate on some of those early trials to have some real winners in patients who got onto the trials, and they're the ones who drove the success. So for example, menin inhibitors, which are very, very exciting targeted agents for NPM1 and KMT2A mutations and rearrangements. These are complicated to remember as a patient, but there's a cool drug out there that might be for you. And I think that patients to really think about asking the question wherever they are that, hey, I just got a diagnosis of AML. Is there a clinical trial that might look good for me? I think is a great question to ask pretty much out of the gate.